Tara Williams, welcome back. This is Sonographers After Dark, and I am joined by Anita Moon Grady. And welcome. Thank you so much for joining me. I appreciate it.
Well, thank you. It's nice to see you again.
Yeah, you too. I know it's been a little while. So I've spent a little bit of time with you kind of clinically in your lab. And so I have a little bit of kind of a backseat understanding of how, you work with your patients. And I've always appreciated that. So, obviously this podcast is kind of sonographer focused, right? So, I know a lot of the talks you give are that high level to residents and fellows. And so obviously sonographers as well. But, there's, I think, a little bit of a difference between maybe some sonographers that are MFM focused versus that fetal echo pediatric echocardiology focus. So tell me a little bit about kind of how you select sonographers in your lab and how you train them, because I know there's a lot of cross training that goes on for you guys as well.
Mhm. So I'm a pediatric cardiologist at UCSF, and I'm a pediatric echocardiographer. So that is where my clinical focus sits, is actually in pediatrics and not in obstetrics. But as you alluded to, there's a lot of overlap between obstetrics and pediatrics in this area of fetal cardiology, and I think it's something that none of us really could have foreseen 30 years ago. And so there are different ways of doing things. Um, and I'm sure you've covered that in your podcast in the past. So I'm gonna say where my our general approach, what our general approach is here from the lens of starting with pediatric cardiology. So all of our sonographers are cardiac sonography trained. So they all trained in adults and then did extra training in peds. My understanding is that that's sort of a standard pathway. So they're all RDCS, and they come to us usually with some peds experience, although we have trained people right out of school. We do from time to time we do host students from the different bachelor's programs, and sometimes we have kept them and hired them. Sometimes we've hired people that we know from the community or that applied for jobs, but have little to no pediatric training, and some of them are pediatric trained. Um, we have two positions generally at the UC system, and I've only ever been here, so I don't know if it's different elsewhere. But we have principal sonographers who are all of the above, and then with years of experience and teaching responsibilities and your fetal boards, you can be a principal sonographer. Sorry, the previous one was senior sonographer. So principal sonographer, that's sort of as high up as they go, and there are requirements for that. But for the purposes of this conversation, one of those requirements is that you have to have your fetal boards. So if people come here with their fetal boards, that's great. We've hired, I think, two people from the East Coast that fit. But the vast majority of the sonographers that I've worked with have been people that I trained or that my predecessors trained here at UCSF. So we already have the cardiac sonographer, and they say, I want to do fetal echo because that's the next step in my career path, and that's the next step in my promotion path. And we train one person at a time. So whose turn it is, that is out of my hands.
Yeah.
But I will train anybody who's already one of our own people if it's their turn to train.
Yeah, and I think that goes back to, why your lab is so, you have a lot of complexity there, right? Because it's not just doing some fetal echo, you have the fetal treatment center as well. So there's interventions that are taking place.
Yeah.
So talk to me a little bit about how you work with that team as well.
Yeah. So we at our new hospital in 2015, we moved here. I guess it's not new anymore if it was 10 years
Yeah,
ago.
it's 10 years
Um,
ago. That's crazy.
Prior to this, the fetal cardiac program and the fetal treatment center were physically separate. And when we moved from our old home at UCSF up on the hill on Parnassus, when we moved to this newly built space, we told them we wanted to physically be in the same space. And so we are in the same outpatient department now with fetal with the fetal treatment center. Um, the advantage there is that sort of 30% or so of our referrals that are fetal treatment center patients are sent here from all over the region. Some come from even different countries, certainly different states. If they have an anomaly that it needs to be evaluated by the fetal treatment center, and part of that evaluation includes a cardiac evaluation, then we're all co-located. So if it's twin transfusion or diaphragmatic hernia, where they need to rule out structural heart disease, we do that. But we also have to understand what the hemodynamic challenges are to those specific types of lesions. And there are others, high output lesions, anemia. We're running clinical trials for stem cell therapy and intrauterine transfusion therapy. We're part of enzyme trials for hypertrophic cardiomyopathy with the fetal therapy for that. So we're not just about the structural heart disease. We have to understand all of these other complex things that where cardiac is just a piece of their evaluation. I would say that the relationship is great. We work together pretty seamlessly, and it's a great um, opportunity to sort of expand your horizons as a sonographer. I think all of the sonographers that start on their fetal training are just amazed at how many things they don't know about pediatrics and about heart function. And they're amazed because by the time they're training with us, if you were listening to my timeline there, they've already been pediatric sonographers in a big teaching hospital for several years. I mean, they know the difference between, a Fontan and a Yasui, and they will tell you every single diagnosis in the heterotaxy, obstructed total veins, interrupted IVC. Like they know all of that, and then all of a sudden there's so much more to learn. And I think that that's the benefit of having the two programs co-located. Now we do lots of bread and butter fetal cardiology. We see lots of patients that just come in for a fetal echo. They're expecting it to be normal. They ask us, I ask any other questions. They ask me what's the sex of the baby, that kind of routine stuff. But I think that the thing that makes it really interesting is all of the abnormal patients that we get to see in our practice.
Yeah. And that's obviously challenging because your sonographers obviously scan ahead of you and then you come in and kind of wrap up the case, right? So, and I think that's pretty common in any pediatric cardiology setting. That's different than if you're in an MFM setting maybe or another scenario, but when you're dealing with such complex cases, you have to have that kind of double oversight too, but your sonographers have to catch those things as well. So yeah,
Yeah.
and that's a lot of responsibility. So talk to me about, I guess, you helped to develop the ASE fetal echo guidelines, which we've actually talked about before and recorded a session on for industry in the past. So
Yeah.
talk to me about kind of where that came from, and anything you want to say about that.
Oh my gosh, how much time do you have?
That's up to you. I'm on your
Um,
timeline.
right. So fetal echo guidelines. You know, it's interesting to me that I got involved in writing guidelines almost by mistake or sort of out of a little bit out of frustration. Um, uh, Back in I would say 2008 or 2009 accreditation was, I mean, it's always been a four-letter word, but it was fairly new at the time. And UCSF had what at the time was ICAL accreditation, IAC accreditation for echo, transesophageal echo, and fetal echo. And the state of California was in the process of starting nuchal translucency screening and paying for nuchal translucency screening, and the reflex fetal echo that you were supposed to get if your NT was above the 99th percentile. Seems pretty simple. So, somebody does a state screen, they send the patient to me, and I do the fetal echo. And they were all kicked back because the state said that the only accreditation they would accept was from the AIUM. And I said, well, we're accredited through the IAC. And so, long story short, I started looking into what's the difference between accreditation between one and the other, and came upon guidelines for performance of the exam and for referral for the exam, and they were very, very different. One of the accreditation bodies was extremely, extremely rigorous about certain things, and the other was extremely rigorous about different things. Some
Way
of them had
different.
to do with imaging, some of them had to do with record keeping, some of them had to, but they were whichever bucket you could put the topic into, they would have opposite opinions about it. Maybe a little bit of an exaggeration, but that's me.
Yeah,
Um,
I think that's
so,
accurate. Yeah.
so
Yeah.
I was really intrigued by this, and I've always been a sort of if you can't beat them, join them kind of person. I'm a what do you call it? I like to compromise. I like to bring people together, and so I just got our lab accredited by both, and then
Works. Yeah.
then set about being involved in multiple different organizations that cross both obstetrics and radiology. So ACR, AIUM, SMFM, ISHWAG, and ACOG, and of course the American Society of Echocardiography, and um, and tried to be aware of what every organization was doing in terms of published statements, white papers. And then when it came around to guidelines, I found myself in the position of not even like, they asked me, hey, Anita, don't you want to be part of our guidelines update group? Or don't you want to be part of our guidelines writing group? So I just said yes to everything. And we have it's not just me, but we have over the last 10 years or so made a very concerted effort to be on as many guidelines writing committees as we can, and at each step tried to harmonize the guidelines so that they say the same thing. And my sort of culminating, my crown jewel in all of this is the recent ASE guidelines, the American Society of Echocardiography guidelines, which had last been updated in, I think, 2004,
It was a
with
while. Yeah.
Jack Reitchick being the head of the writing group. They
Mhm.
came around to needing to be revised. And so Mary D'Onofrio and I stepped in and said, let us lead the revision here, knowing that Mary and I had just been on the writing committee to revise the AIUM guidelines, and that I had just been on the writing committee to revise the ISHWAG guidelines. And I said, we're going to make them all the same. The
Yeah.
screening is going to be the same views, the same expectations. And where we couldn't get um, uh, consensus, say pulse wave Doppler of the pulmonary veins. Okay, we're probably not going to be able to get something that detailed the same across all, but at least we put tables in some of these guidelines to call out where the guidelines were different, acknowledging that they're different, that something may be required in one guideline and optional in another, but being really transparent about it. So that has been sort of the long answer to your question. How did I get involved in guidelines and how do I look at them? I think that the bottom line is, when I started, I realized that if a patient had a fetal echocardiogram in one place or another place, they were probably getting a completely different exam. And they were getting a different quality of exam. They were getting different training for the provider that was reading it, different equipment used, different, like, just, it was just not guaranteed to be the same at all. And I didn't think that that was right. And I think we're at a place now where if you go in to have a fetal echo, you can pretty much expect that you're going to get the same exam whether you go to an MFM, radiologist, or pediatric cardiologist.
Yeah, I mean, I think it wasn't that long ago that the AIUM guidelines didn't even include moving clips, right? So,
Right.
yeah, I mean that's a challenge when you're looking at the heart. You kind of have to see it move. So, I think, kudos to you and everybody that was part of that writing group across the board. I think that, that bringing it all together helps sonographers too, right? Because then we know what we need to do. And so, we're giving you the best information possible to make the diagnosis. And so, I think that helps bring everybody together on the same page. So, and then, I know you've had involvement also with the Fetal Heart Society as well. And that's something that's kind of come about recently and really bringing that organization up. So let's talk about that a little bit.
Yeah. The Fetal Heart Society actually started out as a small group of people who had done some research together, collaborative research together, and found it to be so uh, paperwork heavy and so legally uh, just unsurmountable most of the time, that unless you had someone pretty much full time working on data use agreements and image transfer and IRB and getting emails out to people and getting secure emails out to people, and that you just couldn't work together. And we were at the same time publishing, my series of 35 patients with coarctation and your series of 20 patients with total anomalous pulmonary venous return, and somebody else's series of 3 patients with AP window. Like, there was nothing in the literature that you could go to relatively common diseases and say, what are the general expectations for outcome for this pregnancy? And heaven forbid it be a really rare lesion. There was just no way, because people were just publishing individual case reports. So we recognize the need to work together because of the nature of the disease that we're treating. And we recognize that even in places like Boston and CHOP and UCSF, that it was really hard to work with other institutions. So we said, look, why don't we form a nonprofit that's independent from these institutions and form a consortium of people who are willing to work together on research. And at the same time, we will advocate and we will teach and we will mentor, because it doesn't matter if all of the people with gray hair are doing the research together. If we're not teaching the younger generation to also do the same, then we're not doing anybody any good. So those were our pillars: research, education, and mentorship. And we've added advocacy to that as a pillar. And right now, we have over 20 active research protocols. We have 20 or 22 publications as the Fetal Heart Society in peer-reviewed literature, and we have many more coming. We've run one prospective trial of transposition, and we have helped to recruit, although we're not running these some other trials that are either NIH or Canadian Institutes of Health Research funded randomized trials and prospective trials. So I think that we're very proud of that. Our next step has been taken already, and that's to go from just a North American organization to an international organization. And I would say that's where our education arm is really going to shine, because I hate to admit, but I don't know that I have the lifespan left to be able to develop easy multi-center research among different countries. But
Yeah. That
because that's a
that's the challenge.
whole nother legal challenge. But what
Yeah.
we can do is share our expertise and educate and mentor sort of globally. So we have a global affairs committee that is being chaired by Eduardo Macias from Texas, and Mary D'Onofrio from Children's National in DC, and they're doing just an amazing job putting together um, uh, groups from all from Europe, but also from many low and middle income countries in South America and Asia, and getting the actual providers together on calls to say, what do you need? How can we help? And how can you help us? Um, so we're hoping that all of those uh, resources will gradually become available on our website. We don't have any industry or even private funding at this point. Um, it's all a little bit of philanthropy and then a lot of philanthropic sponsorship from our home institutions. And some people that are paying individually for membership, which does bring me to who can be members of the Fetal Heart
Yeah.
Society. That's going to be your question, I think.
That
Um,
was my next
but
question.
yeah,
Well,
so
and are
we
sonographers involved?
absolutely. Yeah, as a matter of fact, this in the upcoming SMFM, I was just answering the emails from Katie Jo Stoffer, who's a sonographer at Stanford, who is chairing an educational session at the upcoming SMFM that is a joint session with the Fetal Heart Society. So Katie Jo is our Fetal Heart Society representative there. Um, we've had other sessions chaired by well-known MFM sonographers. Michelle Perez has been very involved in our organization, and so is a committee chair for us. So yes, we have sonographers in leadership. There, we don't say that an MD has to be a research lead. We just say that you have to be a full member. So that full membership is open to anyone who has an interest in fetal cardiology. So sonographer, radiologist, could even be a parent. I mean, we haven't had one yet, but it does not have to be an MD. They just
Oh,
have to be interested. And the full membership, I think, is going up to $300 a year, but it was $250. It's not very much. And with that, you can be a full voting member and you can propose research projects as the principal investigator. Now, if you don't want to be a voting member, a committee chair, or the PI on a research project, say you want to be a committee member, not the committee chair, but if you just want to be a committee member and get involved, or if you just want to join our webinars, or if you want to do research by contributing, but not being the driver of that particular research project, then all you need is affiliate membership. And affiliate membership is open to anybody. It's encouraged for fellows, sonographers, nurses, and that I think might be going up to $75 a year. But
wow, that's
it's
so cheap.
really it's
Yeah.
really just meant to be pay us something,
Yeah.
and we'll put you on the mailing list and get as involved as you want to get. But the other thing that we have is for the institutions that have been so kind as to sponsor us. Sort of the in-kind exchange there is the institution will be on our website, and we'll also waive membership fees uh, for a certain number, depending on what level. We'll waive membership fees. So a lot of our sonographers are members through that. Their institution um, it is an institutional sponsor, and they may get unlimited affiliate members. So they just give us the name of every single sonographer or nurse coordinator, um, fetal therapy nurses. They're all welcome at that level.
Yeah, wow. And I think one of the things I love is that you don't actually offer industry support. And I say that obviously, I've been in industry for a long time, but, I think that that really, because it's so research heavy, that, and maybe one day you'll make the decision to do that, you never know, but I think that it does keep that research very, it keeps the line drawn, right? Because there
Mhm.
has to be a line between industry and research, and sometimes those get blurred a little bit. So,
Yeah,
yeah,
yeah.
I think that keeping
I mean,
it that way is
to
probably
be
really
clear,
good.
I will take donations from anybody. So
Yeah,
industry is welcome to write us a donation, and we will put their name and their web link on our webpage. And we
yeah.
even we're in talks with one group where some of their industry like applications people and salespeople are interested in research and education, and so they actually
Yeah.
want membership, and that's fine.
Yeah.
That's we're totally willing to do that. Um, but yeah, but the industry does not directly fund anything that we do, which
No,
I think
and
gives
that's
us it helps us, of course, protect our nonprofit status. We are a 501(c)(3) registered nonprofit.
yeah. No, again, I think that that's good. I think I actually looked into it for one of the industries that I represented at one point and was like, wait, they don't allow industry support. So yeah, but
Yeah,
that's okay. That's all right.
yeah.
So, when we look at, again, bringing it back to sonographer involvement in that, obviously that's key. And then, cross training a sonographer. This is something that I've started offering actually on my educational business, is doing some cross training where, because you're cross training in a lab, right? But they might not have that didactic support. So how do you go about kind of from beginning to end, giving them the obviously hands-on, and you're teaching them with learning experience, and there's that we can't do that in a 12-week cross training course, right? There's no way.
Right,
But
right.
that part they have to get, hands on. But how do you do that and bridge the gap between pediatric echo? I mean, yeah, they've learned congenital heart defects, but approaching it from a fetal perspective is completely different. So how do they go about that? And how does an advanced sonographer kind of bridge that gap and crossover?
Well, I would say it depends on sort of where you're coming from. If you've been a sonographer forever, but it's cardiac, then you do what I was talking about. And I'll just say that I had this discussion with Dolores Pretorius, if anybody remembers her, because we realized that we teach in completely different ways because we are teaching different types of professionals. So I would say it is easy to train uh, a cardiac trained sonographer to do limited obstetrics that they need to be able to do a fetal echo. Like they don't need to be able to find the placenta and the cervix, and like they would run screaming if they saw an ovary, but
Yeah.
but they do need to, measure the head and measure the femur and figure out where the fetus is. But once they find heart disease, they're awesome. Like
Yeah.
they're worse at normals, I think. They're more terrified of normals because they're afraid they're going to miss something. But
Hmm.
if it's a truncus, they're like, oh, it's just a truncus. And then they do all the views that they know they need to do.
Yeah.
Um, so they're very comfortable with the heart disease. Now, if you're an obstetric trained person or an abdomen or general trained person, then you may not know what all of these heart lesions are, and you're definitely not used to looking at the different segments of the heart and assuming that a vein can go anywhere and an artery can be present or absent. You're just not used to that. You're more used to pattern recognition and what does a normal look like. So I have trained MFM physicians, fellows, um, and had to change the way that I look at teaching them. Say, this is this view, this is this view. What's wrong with this view? Not what's the diagnosis or what does this look like, but what about this view is not normal to you? And then
Hmm.
working forwards from there instead of working backwards from a diagnosis. Um, so another long answer to what should have been a simple question, but I would say a really well trained cardiac person can do fetal echo with a couple of maybe months of kind of proctored, mentored learning. And as long as you're doing it every day or at least 2 or 3 days a week and seeing enough disease, a as opposed to an obstetric or abdomen trained person, I think they can learn the normal heart views in a couple of sessions, like you said. There,
Yeah.
but then when it's abnormal, that's where you have to say, well, how long is it going to take to train them? It depends on what they're going to do. If they want to be at the level of a fetal cardiologist, like if they want to support a fetal cardiologist, it's going to take them at least 6 months, maybe up to 2 years. That's how long it takes us to train cardiology fellows about
Right.
congenital heart disease. It takes them 3 years. I'd say after the first year, that's when the steepest learning curve is. So that's why I picked those numbers out of the hat.
Yeah.
I think that 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 it's a different type of learning and a different knowledge base that goes into it. But we are happy at UCSF. We're happy to train anybody who wants to learn. We have cardiology fellows, fourth year imaging fellows in pediatric cardiology, adult congenital heart disease fellows. We have maternal fetal medicine fellows, nurse practitioners, and fetal therapy nurses that we have been happy to train as much as they want to learn. Um, Even people from the outside have occasionally come, like, so not our own employees, but we've had people come from Chile and Vietnam for 3 month or 6 month observerships to try to learn from us. We've always been very open that way. It's also always happy to, if I can't help you learn, I will find somebody who can help you. I know people in programs all over the world who we've either trained or some of them trained me. It's a pretty small community, and
It is.
we
Yeah.
all have the same goal, that of excellence for pregnant people and their fetuses.
Yeah. So, I think the other question that I have also is just what would you recommend to a sonographer who doesn't really have resources near them, and what they can do to just really learn everything that they can, and how they can grow their career with that as well. And I'm speaking more about cardiac sonographers, not necessarily MFM.
Okay. So for the cardiac sonographers, if you're interested in fetal, I would start with some of the online uh, uh, courses that are available. My favorite textbook is by Alfred Abdulhamid and Robbie Chowie, and they have a free version of basic obstetric scanning, and then they have a very reasonably priced fetal echocardiography textbook. So that's a really good resource, especially the free one. And the uh, the YouTube and Instagram accounts of a lot of people have some great content. If you're in the under 30 age group who has I have two kids in their 20s, so I can say this. If your attention span isn't long
Yeah.
enough for a textbook,
Yeah.
I would highly recommend just looking around on YouTube for sonographer produced cardiac content. Again, Michelle Perez, I'll say her name again comes up over and over. Tracy Anton.
I think Joe
Uh, th-
Krieger has
there
some as well.
Joe Krieger. Yeah, there are a lot of people who just follow them and, you know, open up your Instagram, and instead of finding out what our federal government's been up to, just watch a YouTube video on the four chamber. Um,
Yeah.
so lots of good stuff out there. And then when you're ready to actually, like, start scanning patients, work with your physicians to get as much transducer time as you can, scan as many normals as you can,
Mhm.
because you can't know, if you don't know what normal looks like, you're not going to recognize abnormal.
Right.
You have to be sure that you know what normal is, know how to demonstrate a normal, and then you'll be confident that if you can't make it look normal, it's not because of your skills, it's because of the baby.
Yeah. There's something going on there.
Yeah.
Yeah, absolutely.
And then, a couple of weeks of either observing or even a couple of days of observing in a bigger program. There are a lot of fetal therapy programs. There are over 50 members of the North American Fetal Therapy Network alone, and not every fetal therapy program is part of the North American Fetal Therapy Network. So that's NAFNet, and you can go to their website, NAFTNET .org, and see where the programs are. Contact the cardiologist there, or contact the MFM there. Ask if you can spend a day, a week, a month in their lab. Especially if you're part of one of their referring practices, they're probably going to be happy to have the sonographers there, just seeing what we do. And then finally, there are, if you're in a smaller or private practice type of setting, I have in the past been quite thrilled to go to the practice with the blessing of the practice manager or the physician running the practice, and just work with people for a day or two, helping them scan or bring back or do a noon didactic of their own cases that they sent me, and what did I find? They identified it as abnormal. What did the baby actually have?
Hmm.
So work with your cardiologist that you refer to, because most of us we're pretty geeky about this whole thing. We'd love to show people what we found. So
Right. Yeah. Sharing the knowledge for sure. So,
Mhm.
yeah, is there anything else that you think that, could benefit a stenographer or even residence fellows, really trying to dig into fetal echo?
I would say um, the fetal echo guidelines that we mentioned, the ASE guidelines,
Mhm.
are something I'm very proud of, is the fact that it doesn't just teach you how to do a normal fetal echo. It really, the whole second section of those guidelines, um, the idea was, okay, you're training fellows or you're training sonographers. What do they need to come to you when they think they're done with an exam? What do they come to you with? They don't just come to you with, oh, well, there's a VSD with aortic override. I want them to have already thought, okay, I looked for LSVC, I looked for AV valve regurgitation, I measured the pulmonary valve annulus, and the Z-score is this, and the PAs are continuous. And like there are certain things that go with tetralogy of Fallot or hypoplastic left heart syndrome that someone who's doing the scan should know to do, but they weren't born knowing it. And so these fetal echo guidelines tell you what to do and what constitutes a full fetal echo if it's normal. But the new fetal echo guidelines also tell you what constitutes a complete fetal echo if it's abnormal. Um, so I would encourage people to kind of carry that around, and know that a lot of thought went into those tables, to try to condense down what's a textbook's worth of information into just a guideline statement that's open access and freely available to everyone. It also has videos. So if you're in a country um, that has bandwidth and that allows the download of the videos, you can access the videos through the ASC website.
Yeah, it's so comprehensive. I mean, I don't think I've ever seen a guideline quite like it, honestly. So, it's because, and I think that it helps to bridge the gap between maybe some rural centers and care that's being provided outside of, the main centers like UCSF, right? So you're working with physicians that are providing care, but they don't have access to the type of level of care that your center gives. And so it really helps to kind of bridge the gap in that divide, that they're going to get the same quality of care, even if they're, in rural Ohio, where I'm sitting right now, versus, at UCSF in San Francisco. So, I think and I believe that was probably the intention of that as well.
Yeah.
So,
Sort of
yeah,
to democratize the entire process and not just keep it in our ivory towers.
yeah, for sure.
Exactly.
Awesome. Well, thank you so much. This has been a great conversation. I
Thank you.
appreciated your time so much. I think that this is helpful for people who are looking for just resources in general and to know how to move forward. I guess, what do you wish, one last quick question, what do you wish that every sonographer in fetal echo understood about their impact that they make when they put that probe down?
Oh my gosh.
It can be short or not.
um, I would like to end on an up note, but maybe I'll end on a little bit more cautious of a note. As excited as we are and as fun as fetal echo is, this exam is life-changing for these families. And we break hearts. They come in with one baby and they may leave with a completely different world. And I think to treat all of the families as human and with care is so important. And the reason the sonographers need to know that is you're the first contact, and you are, in a lot of cases, going to know more about this baby's heart than anybody else could possibly know. And you owe it to the family to do your best. And to treat them with kindness. So try to keep that in mind. This isn't just a job. And cardiology, congenital heart disease is common enough that anybody who scans pregnant people is going to see it.
Yeah. And it's so easy to get frustrated. Sonographers get overwhelmed. There's a large patient load. There's for physicians as well, obviously. And I think the post-COVID era of just we can't keep up with everything. It's difficult. It's staffing shortages across the board. And so, sonographers as well as everyone in healthcare is overwhelmed. So it's easy to just kind of get through your day and not really look at the patient that you're dealing with and understand their impact. And they're coming in, they're scared, right? They don't know. Some of them, like you said, they just think it's a normal exam and they want to know the gender, and they don't really understand the news they might hear if there is really complex congenital heart defects. But others, they know there's something going on, and they are so apprehensive. And so then they're having, the sonographer has that role to kind of comfort them a little bit as well, so and then you get to come in and unfortunately give sometimes some very difficult news, but every once in a while, and oftentimes good news too. The relief comes as well. So
Yeah.
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 Well, thank you again. I cannot thank you enough for. I know it's extremely valuable, and so I just want to say thank you. And this has been another episode of Sonographers After Dark with Anita Moon Grady, and I will see you next time.